Assalamu alaikum. First of all, thank you, Ahmad, for the invitations. And this is great to be the first conference. We know it's sometimes difficult to start, but I think future usually will the next conference. And also thank you for the Scientific and Graduate Committee for choosing the lecture. So I know it's the end of the session, but I hope to be interesting. People like endoscopy, that's nice. So my role today is very huge. I try to summarize it in very concise slides. So the role is just the role of EOS and hepatobiliary malignancies. So this is my disclosure. And then I'll mainly touch on the history of EOS. How to track and progress in EOS, and then I'll talk about the advanced EOS technique, mainly covering the oncology patients, diagnostic and therapeutic technique, talking about some effective studies, give us a clear evidence how to manage our patients, and then in terms of the biopsy, FNA, and also interventions, biliary drainage or drainage of the gastroenterostomies. Then I will talk about some of the comparing EOS to the traditional AI in surgery. At the end, we'll see the more advanced or innovations of EOS. So everybody knows the history of EOS. This is the history. So it started by 1980. Then 10 years of diagnostics, and mainly diagnostic and radial. Then after that, followed by 10 years giving the linear and having some 10 years to understand the anatomy. This is good. And after that, we have the first FNA. It was 1992, and the first FNA was performed in Denmark. Then after that, we have a lot of interventions, and it was started almost 2 decades from now, 2001 by Mark Giovannini. Then we have the LAMS. It opened the gate for all the interventions in our patient daily practice. If you have the journey of the therapeutic EOS also, we have some of the good to know. It was started in 1992. The first was cystoenterostomy, followed by colodoco enterostomy, and then draining the pancreas to the small bowel, then followed by Ted Barron's gallbladder drainage, what 2007. Then after that, we have the LAMS in animals, and then in human was published to have anastomosis. All these very important to then progress to a lot of intervention in our oncology patients. So this is what you have to consider. This is the role of EOS in oncology patient. You can inject, you can have a tissue, and then inject the material, you have anastomosis, and also drainage of your patient if it's failed DRCP or any other modalities. Then think about any metastasis, you can biopsy, duct drainage is very important. More and more, the most important, only you get a tissue, but now there's a lot of things beyond the tissue. So tissue acquisition, very important, moving from FNA to FNB, then injection of a lot of material. Mainly I'll talk about the RFA, the role of RFA in a cystic lesion or mainly in the pancreatic adenocarcinoma, and then injection of material, including also the celiac plexus neurolysis. This is some of the things usually you have to consider if you have a patient with pain, so celiac plexus or neurolysis, chemotherapy, or fiducial to treat your patient pain control. Then if you have more information about anything around tumor ablation, we have a lot of evidence of RFA, but the other is still ongoing, so we'll talk about RFA. Now if you talk about the main role that starts on mainly tissue. People, they are moving from FNA to FNB for a lot of reasons. Even you can perform, if you have very small lesions here, as you see, this is a distal cholangio. It was very small with a stent, and you have to use the needle. It's easy to be inserted, and you can see to take a tissue, and then you have to make sure about diagnosing the patient from the first few passes or the first procedure. And this is the evidence behind that. We have a lot of studies, but I have to present at least. People sometimes they ask what type of needle you can use or how many passes. This is a comparing of the new design needle to the Francine needle. There is no difference between them, and usually you see the sensitivity here is very high, and you can diagnose the patient from 93 to 98%. Compared to all lesion, pancreatic alone, or maybe it's other biliary masses. As you see, is also if you perform a procedure, you have to be away from necrotic, and then you have to choose the area of the tissue. You can use also Doppler to be away from any vascular or to have a vascular path. then you're choosing FMB needle 22 or 25. Nobody use 19. You have to see the needle and then make sure you go through the mass, and then probably at the end you can have the clear tissue. Now, if you see, this is very clear, all systematic network meta-analysis of a lot of randomized trial, having a lot of patients, comparing the standard of care FNA to a lot of types of designs of FMB. As you see, there's a lot of big strength here between the FNA and fork tip needle. But at the end, all these needles seem to be, the Francine is better and also superior to the other with also fork tip needle. So you can choose what you have, but this is the two needles you can give you high yield and also the diagnostic accuracy in terms of the symbol adequacy is almost the same. Now, if you compare to the scoring high for the both sample adequacy on diagnostic is almost Francine needle scoring is a high among the all type of FMB needles. But in reality, is just try what you have, and then probably at the end you will get enough tissue. This is something also to compare if how many passes you have to perform. So most of the people, they don't have any clear study. This is a systemic review or a randomized trial. It's comparing that a lot of passes, 1 to 2, 3 to 4, 3 to 4 or 5. So it's clearly shown that 3 passes is give you a good accuracy, adequacy, and high yield by almost by 2 folds or more, and around almost 1.54 accuracy, and no benefit if you can perform more passes. So 3 is enough, and they conclude in this study that 3 are optimal, and 2 you have to have sufficient to have tissue, or maybe you have to have a diagnosis. Beyond the tissue is even this is the molecular profile. Very important nowadays. This is a randomized trial performed in Orlando. Give us 2 passes and 3 passes is very important to have enough quality of DNA and RNA, and also as you see here, almost around 12% it can be affect the management of mutations, and you have positive mutations. And also the 2 passes is enough to have enough tissue. I think EU is evolving, taking the tissue, sampling, and also performing a lot of molecular studies is very important. Again and again, also organoid, this is one of the new study, this was published in Korea, give us clearly that you can have some of the 2 weeks short time to have organoids of extracted from the FMB compared to the surgical standard of care surgical tissue. You can then perform histology, pathology, and also genetic sequencing with biobanking for your patient. So the benefit of this study is you have to have the sensitivities of the chemotherapy to your patient. As you see, they conclude that this is a very good, it can affect our practical or the practice in our patients. Number 2, it was very quick evaluation within 3 weeks. Number 4 is major advantages of personalized medicine of pancreatic cancer. In addition to that, usually those patients in inoperable, they need to have some of treatment. So moving beyond the tissue acquisition, now you think about the drainage. You have a lot of procedure to drain, either rendezvous or bile duct, what they call it from the duodenum is choledochidinostomy or hepatogenostomy, or maybe a gallbladder drainage as a palliative care. So this kind of procedure, you have to understand the anatomy of the liver, and mainly you have to know what is the intervention. Usually in segment 2 and segment 3, if you have to think about either the hepatico or maybe rendezvous. Now, this is one of the patients. So our patient long time ago, this is a couple of years, ambulatory tumor, cannot perform ERCP, rendezvous is performed and stented, and then sent to surgery, bilirubin is very high. Then this is another patient having the choledochidinostomy. It's easy to perform a failed ERCP in the same procedure, so you have to consent your patients for both, for ERCP, if failed, and then EUS, and then you can do the procedure in the same session. You will not bring the patient back again to do the procedure. And this is the third procedure, hepatogastrostomy. If you failed and then you don't approach duodenum, if you have a gastric outlet obstructions, then you have only one option, either gallbladder or maybe you have a hepatico to perform the either retrograde or antegrade stenting or rendezvous of those patients. Then at the end, you see the evidence. Is it better? Is US better? As you see, this is almost systemic randomized studies done by Rim Sharaiha, as you see, is more of 9 studies with a good number of patients, showed that the clinical success and also post-procedure adverse effect with re-intervention is favoring the EUS. And the cost is almost with the EUS patients. So very important to consider this procedure if you have a suspected difficulty from the beginning. And then you see this is another trial was performed compared to both percutaneous ERCP and also to other to EUS. They favoring EUS also. Reinterventions, pancreatitis less, growth, tumor and growth is less, and also hospital stays is less. Hospital staying is less than comparing to ERCP or percutaneous. If you failed all this procedure, still gallbladder is considered to be as a rescue therapy for those kind of procedure. I know the gallbladder drainage can be done for benign, but you believe it or not, it can be also done for draining a malignant biliary strictures, and mainly is you have a distal biliary strictures. So this is the evidence behind that. This is a multi-center retrospective studies in tertiary care center in the state showing that after third ERCP and biliary drainage bile duct EUS, gallbladder it can be one of the option to treat your patient, as shown here clearly that the success rate is very high, and then drop of bilirubin is very significantly, and you see the stent patency is more than 82%. So if you failed all procedure, still you have a room to do gallbladder drainage. Complication is still there.
2 minutes left.
Okay, the complication is still there. So and then you think about the if you have a patient with the gastric outlet obstructions, you think about the EUS gastrogenostomy, standard usually surgical and also duodenal, but this can be done either direct or balloon assist. Then you see this is the evidence of those patients. So the evidence is clearly showing that is the re-intervention is less, assuming the diet is more than 3 days. Chemotherapy can be resumed within 1 week compared to other modality, which is the surgical or the stenting. As you know, the patient suffering from pain. So this is the clear one of the systemic review meta-analysis showing that comparing the 3 modality of the central or bilateral or the ganglia, there's no difference between both, but the more complication with the bilateral. So if you have a patient, you can use only unilateral and having some of the good response, around 70% of response rate of controlling the pain. But I will not show this study, but comparing to the baseline is very different between the baseline pain, but no significant if you compare to the control to EUS. So now they're recommending that either you can have the patient pain control or you consider the EUS neurolysis an optional for your patients, not like before it was very promoted to be a good method to treat your patients. RFA also very important. This is one of the study from France, from Napoleon, is give you clearly that we know the RFA can be used in a cystic lesion, but this study shows 100 patients with the almost in the adenocarcinoma patient, they have a good response rate around 60%, but the problem here, the complication is very high, especially of the lesion close to the PD, have the complications rate is high, and there is a predictor for the response if the tumor less than 20 millimeter, and also neuroendocrine tumor is better than adenocarcinoma. Fiducial is the gain to target the radiations. As you see, this is prospective studies of a good number of patients, and they have to consider that the fiduciary can have a targeting radiotherapy more than 92%, and also with a 62% of the high quality success rate. Complications very low and around 8%, and there is no serious complications reported. So at the end, I know the topic is very huge, so we have to wrap up. Is EUS give us a lot of diagnostic and therapeutic in our daily practice and mainly oncology patient, and usually the new technique is give us a clear map for managing oncology and therapeutic intervention compared to others, and also you have to understand the accuracy of advanced tissue acquisition, mainly FMB. Is nobody do FNA now because you have to do a lot of subsequent tests for the FMB. At the end, usually drainage of the bile ducts is very safe and effective compared to the AR and surgery. And then also you have to think about cost effective. In the past, in Saudis, we don't care about the cost effective of this procedure. Now we have to care about the cost effective and safety. At the end, the new emerging comprehensive molecular profile with organoid is a new procedure to have a way for personalize your patient or approach for your patients. So at the end, I will thank the team. This is our daily conference, and I know most of the people they attend, and this is the next conference will be February 13 to 15 next year. Thank you.
So we're going to go through the program quickly.